Here's lesson 10 in the trauma unit, lesson 10 in the EMT course. This is on neurogenic shock. Pretty short online prep for this, although the concept may be a little confusing, so you want to spend some time making sure you get the concept down. And then we add this to our study of trauma patients in the lab setting. And so here we go. Things to talk about: the A&P on neuroshock, its definition, its causes, its assessment, and its treatment. Up to this point, you're probably pretty clear on shock. This is a little bit different flavor of shock, and so we wanted to kind of spend some time talking about it specifically, and we tie it to the study of head, neck, face, and spine injuries. We want to differentiate neurogenic shock from patients who are crashing from elevated intracranial pressure, like we talked about in the last lesson. Neurogenic shock is shock that is caused by damage to the spinal cord, whether that's permanent or temporary. In either case, the cord is not able to transmit impulses, cannot transmit commands from the brain. And then we want to talk about how that impacts the body and the autonomic nervous system's two branches, the sympathetic and parasympathetic, and why this matters to you. We also want to talk about categories of shock in general. There's obstructive shock, cardiogenic shock, hypovolemic shock, and then there is distributive shock. Neurogenic shock is one of the distributive shocks. There's also sepsis, there's also anaphylaxis. We cover those in different lessons. And the assessment here is a little bit different from your patient that has straight hypovolemic shock. The patient with isolated neurogenic shock doesn't have, in all areas of their body, doesn't have the same signs and symptoms that you're looking for. The cool, pale, clammy skin and the tachycardia are not there. And so, spoiler alert, but that's what's coming up. And we want to talk about your emergent and immediate interventions, as we do with all of these critical patients. So, distributive shock, which again can be sepsis, anaphylaxis, or neurogenic shock, which we're talking about now. That's the three types of the category of distributive shock. Distributive shock is caused by an abnormally large vascular container. The vessels have dilated. You have inappropriate vasodilation. In the case of sepsis, it's from a massive infection. In the case of anaphylaxis, it's from a massive immune response. In the case of neurogenic shock, it's because of loss of neurosystem control of the blood vessels. And when blood vessels are not told to stay partially constricted or to constrict, they simply take a break and they dilate. And so you have this abnormally large vascular container because the commands from the brain are not getting through to the vessels. So why does that matter? Why do we care if the container size gets huge? Well, if that happens, then the pump, the heart, has got to circulate more volume. And the volume that's there is relatively low. So even if the patient hasn't lost any volume at all, hasn't bled out one single drop, they're relatively hypovolemic, because, for just round number examples, let's say that normally your vascular container is a 6 liter size, and you've got 6 liters of blood. So you have an appropriate amount of blood to fill the container. So what if then the container becomes 8 or 9 liters in size? You're a couple of liters low. Even though you haven't leaked any out, you're a couple of liters low. So the volume that's present is relatively low, and the container space is just too large, and the pressure drops. It just makes common sense, we think, that the pressure drops. So neurogenic shock, why is this a big deal? Well, the brain is monitoring BP all the time, and it sends commands to those vessels and to the adrenal glands. The adrenal glands, of course, secrete adrenaline. You have an adrenaline dump. Adrenaline, epinephrine, causes blood vessels to constrict. It causes the heart to beat faster. It causes the heart to beat stronger. But if the adrenal glands aren't told to secrete adrenaline, they don't just do it on their own. They have to be told by the brain. And if the brain's signals and commands are not being heard, the adrenal glands don't secrete any adrenaline. So you don't get the increase in heart rate or the increase in strength of contraction, stroke volume. You don't get those cardiac compensations for pressure dropping, and you can't get the vasoconstriction from the pressure dropping. And so what happens? The blood vessels dilate, and you have too large of a container, and therefore the pressure goes down. Some students are kind of confused by this neurogenic shock thing and the fact that we just talked about traumatic brain injuries can make that a little bit confusing. And we did this on purpose because we want you to study the two things side by side, back to back. So neurogenic shock has nothing to do with traumatic brain injury. Your traumatic brain injury patient that took enough of a smack to his head to have a traumatic brain injury, that same trauma may have also caused a problem in the spine, but that's not always the case. And so neurogenic shock is not from elevated intracranial pressure. Neurogenic shock is because the cord is damaged either temporarily or compressed or kinked, or there's swelling. So it's either a temporary or permanent damage to the cord, and the brain is unable to send commands to the blood vessels and the adrenal glands and the heart to compensate. So on the ALS side, we've got a couple of tools. On the BLS side, not so much. But on the ALS side, we can give fluid volume, give IV fluids to fill up the container. If the container used to be 6 liters and there's 6 liters of fluid volume, and now the container is 8 liters, well, let's give a couple of liters of IV fluid and try to fill up the container to its new inappropriately large size. When that doesn't work, and frequently it doesn't, when that doesn't work, then we can give medications that will directly vasoconstrict and bring the container back down to its previously normal size. On the BLS side, those two options are not there. There's no option for IV therapy, there's no option for pharmacology. And so urgent, safe transport for definitive care or ALS care is really the only option for these folks. So what's this nervous system thing I keep talking about? So don't want to get too deep in this, but wanted to at least kind of tie this together for you. And some of you have probably some advanced knowledge in this. This may seem oversimplified. Others have never heard of it, and that's fine. I just want to spend maybe 2 minutes on this. Your autonomic nervous system handles automatic sorts of responses. And there's two divisions to that. There's the sympathetic, which is fight or flight, which would increase your heart rate and cause vasoconstriction as needed to bump up the blood pressure. And then there's the parasympathetic side, which is rest and digest. And so the parasympathetic system slows your heart rate, and the sympathetic system increases your heart rate with the adrenaline dump. And so if your sympathetic system can respond, then you can get some vasoconstriction, which would give you the cool, pale, clammy skin. You can get that increased heart rate, the tachycardia. But if the messages to the sympathetic system are not getting there from the brain, then it can't respond. And the only thing left is parasympathetic. And so the two systems are supposed to more or less balance each other out. But if the sympathetic system is out of service because it's not getting any commands, then the parasympathetic is what takes over. And so that's kind of what we see with neurogenic shock assessment. So with neurogenic shock, usually that injury is at the T6, the 6th thoracic vertebra. T6 or higher. And you can have other injuries that are due to that same mechanism. So if you have enough trauma to cause an upper thoracic spine injury, it would seem reasonable that there may be trauma to the ribs and chest. Maybe you have underlying lung damage, whether it be a bruised lung, a pulmonary contusion, or a collapsed lung, a pneumothorax. And so these patients can come with other big problems in addition to neuroshock. But usually it's an mid to upper T-spine injury is the cause. And you can have injury directly to the spinal column, to the bones, that doesn't cause any problem with the cord. You can have injury to the cord and the bones be intact. You can have both. So if your patient has significant trauma to their spine at, say, T5, T6, something like that, then above the line of the injury, and when I say line, what I mean is that more or less the injury to the spine is correlated with the external surface of the body pretty much at that same level. Now, that's not exactly the case. If you want to look at this more further, look up dermatomes, DERMATOMES. Look those up in your book or online. Look at dermatomes, and that shows you the area on the skin, on the surface of the body, that is innervated by nerves that go in the spine at a certain level. So T4 is pretty much the nipple line. T10 is pretty much the belly button. So in general, if you have a patient with an injury at, say, T4, T5, T6, something like that, a significant enough injury to impinge or transect the spinal cord, you're going to have innervation above that area. So above the nipple line, the patient is still going to have his normal innervation and be able to respond with his sympathetic nervous system. So you would still get the cool, pale, clammy skin on the face and the shoulders, but below the nipple line, that would no longer be there. The parasympathetic nervous system would be the only thing operating down there, which is going to give you warm, dry, flushed skin as opposed to cool, pale, and clammy. So that's what we're talking about with the line. I used to say stripe. It's not really a stripe, it's a line. And that line is roughly correlated with the injury. And so you don't really need to know the dermatome chart or carry it with you. It's more helpful for strange sensations on maybe arms and legs, because if you look at the dermatome chart, it's not particularly linear. But on the trunk and from kind of waist and above, it's pretty linear. So if you have an injury at the spine, that's about where your line of sensation and line of innervation is going to be. So another clue that may help you is if that patient can't move his extremities, particularly can't move his legs, that would make you think there's something going on the spine above the waist. And if it's high enough up, it could be impacting the sympathetic nervous system to the point where there's no ability to compensate. So as we've said a couple of times, neuroshock's kind of weird. You would expect your patient who's been in a car wreck or had a long fall and has lost blood, you would expect them to be tachycardic. But the neuroshock patient, the heart rate is not elevated. It's normal, and it may even be slow, because again, the parasympathetic system slows heart rate, and there's no sympathetic activity to counterbalance that. And so you end up with not elevated or bradycardic patients. And this is the patient you come up to, and you feel the radial pulse, and you expect it to be 140, and it's 70. And you're like, well, this is strange. So when you say to yourself, wow, that heart rate doesn't match, then we want neuroshock to pop into your head. The respiratory rate also in a hypoxic, shocky patient, you would expect to be elevated. You would expect tachypnea, an elevated respiratory rate. In these patients, it won't be. It might even be slow. And then below the injury line, like we talked about, that skin will be normal, flushed, warm, but not cool, pale, and clammy. And their BP is going to be low. So this is the key concept that we want everybody to know about and work with there. And so summary-wise, neuroshock is caused by spinal cord damage, whether it's permanent or temporary, and that means that the cord is not able to transmit commands. And so the sympathetic nervous system has no ability to oppose the parasympathetic, and you get that bradycardia, that normal or flushed skin condition below the injury line. That's the big thing. So that's the end of lesson 10. We'll see you in lab.